All right. Guess we'll go ahead and get started. Little endocrine farm going down today. I'm sorry. I did a last second look over my slides and I noticed that I had a drug on there that's not available in the U.S. anymore. So I made that edit. And then I added some questions at the end that we'll go over. So if you looked at the slides, yesterday, they've been updated since then. And they have updated in the title. So you'll know if you're looking at the right slides or not. Anyway, we'll go ahead and get this party started. Let me just go ahead and tell you that the star attraction for today is diabetes meds. There's a lot to chew on there. So I'm really going to ham it up there on that part. And for your studies, not to say that the thyroid and drugs that support the thyroid are not important. They certainly are. But most of our material is going to be about anti-diabetic agents. So plan your studying accordingly. But of course, thyroid is fair game. There's just not as much to talk about. But we'll go ahead and get started. Hey, what do you do if your thyroid is getting a little lazy and doesn't want to make any thyroid hormone or doesn't want to make enough? Well, you're in luck because we can give you some exogenous thyroid hormone. And, there's all kinds of, feedback loops at play with our own endogenous production and secretion of thyroid hormone. But what it really boils down to, and what you'll see in a lot of patient case vignettes, if you will, is, someone's really tired and they're really susceptible to cold and they're bradycardic. And then you check some labs on them, and the thyroid stimulating hormone is elevated, and the T4 and T3 are low. So that's kind of like the stereotypical starter kit patient that you would consider giving exogenous thyroid hormone for. Well, you do have some choices on how you want to do this, though. So, patients that are hypothyroid, you have a whole host of different potential options, and it really boils down to: are you a T4 kind of guy or girl? Are you more of a T3? Or do you like a little mix? Well, a little bit of the finer things in life. For the vast majority of patients, levothyroxine, some people will call it by its trade name, but it's all super generic. Everything is generic now in this realm. Synthroid is what some people will call it. That's the trade name, but levothyroxine is usually the one that you're going to reach for, and that's T4. Why? Why, oh, why? It's not as potent, and you may think that's not necessarily a good thing, but thyroid hormone does have some adverse effects associated with it, and due to its lower potency, patients actually tend to tolerate levothyroxine better compared to a T3 equivalent or a mixed equivalent. So that's bonus number one. Bonus number two is the longer half-life. So it can only be given once a day, whereas T3 preparations have shorter half-lives, and they require multiple doses per day. God knows it's hard enough to wake up in the morning, so who has time to be taking thyroid hormone 4 times a day? One little thing, actually, that I do want to take a step back about is I don't know if anybody here has had the utter joy of being on thyroid hormone or knows someone that's on thyroid hormone, but for the most part, one of the rules of medicine is generic is just as good as trade name, and that mostly holds up. It really does, and it depends on the state you're in exactly what you can substitute out a generic equivalent for. The reason why I'm going down this hole here, though, is to tell you that some patients that maybe they are stabilized on name brand levothyroxine, so maybe they're on Synthroid, depending on how hard their disease was to get a handle on, you may not be able to just put them on the generic, and that's because there is some variability between trade name and generic medications. So this actually manifests at the state level. So, for example, when I was growing up on the mean streets of Knoxville, Tennessee, the law in Tennessee is you cannot substitute, at the pharmacy level, the pharmacist cannot substitute at the patients on trade name Synthroid to the generic levothyroxine, or vice versa. And that's because there can be up to a 20% variability in plasma concentrations. Tell you the truth, I don't know what the law is in Nevada, but this is one of those meds where generic substitution, may not be a possibility, and you have to bite the bullet and just pay for the trade name in some situations. Anyways, for those people out there that require the more unbridled potency that T3 offers, there is a T3 only thyroid hormone preparation available called liothyronine. But part of the reason why you don't see it used as much is, again, higher incidence of adverse effects and the multiple daily dosing. And then finally, there's a combo product called Leotrix. Leotrix contains T3 and T4. And, some people, there's usually a very long, convoluted story of how someone ended up on Leotrix. But sometimes some people's, hypothyroidism is very hard to manage, and it's like the Goldilocks just right amount of potency for them. I did leave one drug off of here because no one really uses it anymore, and I believe it's still available, but I don't know if you've ever heard of Armour Thyroid. What a weird name. Armour Thyroid is horrible. Because Armour Thyroid, what they literally do is they take the thyroid from a pig, and I'm sure there's some more steps along the way, but they basically just grind it up and turn it into pill form. So there's a ton of variability between, different lots and batches of Armour Thyroid. And it's one of the few drugs, I believe, that is dosed in grains, yes, not milligrams or grams. And that is, That's even used much less so compared to the T3, T4 meds. But for sure, 90% of people are on levothyroxine. And hopefully I've convinced you why that's a good thing. So the stereotypical adverse effects with thyroid hormone. So thyroid hormone basically is, just kind of amps you up almost. Kind of interesting, almost like a sympathomimetic type effects, but independent of that mechanism. So you get tachycardia. Patients will be very, they get hot very easily. They'll be sweating, tremulousness. They can have arrhythmia. And then they might actually have, a pretty dramatic weight loss over a period of time. In fact, before the current era we were in, if you wanted to go absolutely just turbo on your weight loss, you had, you only had a couple choices really. You could use phentermine, which is a stimulant, but also has been known to damage heart valves, but people would still use it for weight loss. Thyroid hormone, people would take thyroid hormone to lose weight. I guess people still do to this day. There's just better options out there. People would take thyroid hormone. And then lastly, patients would take like medications that would make them basically unable to digest fats. So the name of the drug was orlistat, and that, you basically would have diarrhea if you ate a fatty meal, so it kind of made you go away from fatty foods. But anyways, weight loss, very pronounced adverse effect with thyroid hormone. I don't know if you've ever seen somebody that has hyperthyroidism. I'm sure you guys have been bombarded with these images in your in the pathophys class with the bulging eyes, the Kash Patel look to some degree. I don't know. That's some of the adverse effects that you can see with thyroid hormone. Pharmacokinetics, oh gosh. Well, there's actually some stuff to talk about here. So this is one of those ones where really and truly it matters if you take it with food. And that's similar to things like tetracyclines, similar to fluoroquinolones like Cipro. That's because it will chelate with cations. So it's important not to take it with anything like calcium or iron. So it's recommended to take it without food. And then cytochrome P450 enzyme induction. These meds are a huge pain in the butt to dial in the therapeutic dose for the patient. There's not, don't get me wrong. There's sources you can look at on what to start the dose at for a particular patient, but 9 times out of 10, that's not going to be their therapeutic dose. It's just the starting dose. So it kind of turns into like a game of like titrating the dose up and down. And if you add any sort of enzyme induction drugs in there, that can mess it all up, so to speak, because some people are really, there's a lot of interpatient variability, of course, but some people are very hard to get to that therapeutic level for them. Okay, enough about thyroid hormone. What if you have the opposite problem? What if your thyroid is working just a little too hard? So in terms of drug therapy, the patient will most likely end up on a thionamide. And there's 2 of those that are used. There's propylthiouracil, which is almost exclusively called PTU, and methimazole. And these drugs simply just inhibit thyroid synthesis. They more specifically, they block thyroid peroxidase and condensation that's required to create that thyroid hormone. PTU, you also pick up a little extra beneficial action in that it inhibits the peripheral conversion of T4 to T3. So if you ever have a patient show up that you're taking care of and they're in thyroid storm, they're super thyroid toxic, like, a medical emergency, you'll see most sources say to give PTU because it has kind of this like two-pronged mechanism in the treatment of hyperthyroidism. But to tell you the truth, almost everybody is on methimazole for just chronic hyperthyroidism, and we'll get to that in just a moment. The adverse effects associated with these medications are rash, very important, the hepatotoxicity. This is like really the inflection point, so to speak, on why methimazole is used more so than PTU. And that's because PTU has a much higher risk of hepatotoxicity compared to methimazole. Both drugs can cause these weird hematologic adverse effects. Another reason why methimazole is preferred, I'll say, over PTU is it's only once a day, so kind of similar to the T4, like levothyroxine is just once a day. Methimazole is just once a day, so nice and convenient. And overall, it has a lower incidence of adverse effects. Not just the hepatotoxicity, that's kind of the major one that we get scared about, but it does have less rash and less hematologic toxicity. You may be thinking, why would you ever use PTU? Well, I already told you one case. If a patient, you're taking care of a patient with thyroid storm in your emergency department or whatever. The other case is methimazole is actually teratogen. So in pregnant patients, it's recommended to use PTU instead. So that is like NBME cannot help themselves with that. They love this fact. They love it so much. This is like something that is just on so many standardized tests. Pregnant patient, hyperthyroid, what do you do? And usually what the question boils down to is just recognizing that in a pregnant patient, you would give PTU over methimazole. So where exactly do these drugs work? Well, this is that condensation step where PTU and methimazole both work. And then they also inhibit this iodination step as well. Okay, that's it. Now everybody just kind of buckle in, get comfortable. We're going to talk about diabetic drugs more so than you ever would want to. So first, we'll start with the parenteral anti-diabetic agents. And this is basically going to be the insulin show for this part. We'll talk about some other stuff besides insulin that are parenteral, but insulin is our marquee attraction here. And one thing to note, which, I guess, and I believe I probably was the same way. Insulin is insulin, tomato. They decrease. Insulin decreases blood sugar. I'm sure there's some differences, but there are some super important differences between insulin, and they are certainly not interchangeable with one another. And the thing to note, just as like a very broad statement with insulins, is, are they basically like a controller insulin, where they basically keep the blood glucose in check in between meals and at nighttime? Or is it a insulin for postprandial glucose spikes? That's literally kind of, in general terms, they usually are in one or the other category. So just to drill down a little bit further, so in terms of those insulins that are for the postprandial glucose spike, rapid acting is going to be the quickest to target that postprandial glucose spike. So you'll find in the common era that anybody with insurance that's on diabetes or that has diabetes and requires insulin therapy, they'll almost always be on a rapid acting insulin to target those blood glucose spikes. So there's not really any super easy way to remember these, but you just got to remember Lispro, Aspart, and glulisine. Those are the three rapid acting. And these and insulins just across the board are totally beholden to their pharmacokinetics. I know I sometimes go on and ramble about how the pharmacokinetic profile doesn't necessarily match pharmacodynamic profile. But in the case of insulin, they are almost one and the same. So with an onset of 15 to 30 minutes, these insulins quite literally are taken 15 or 30 minutes before a meal. With a peak of around 30 to 90 minutes, the meal is still in process or has, the patient is done eating shortly around that peak effect. And then they hang around for about 6 hours. What that looks like then is in this figure over here with the green, Lispro, remember that's a rapid acting insulin. So the B being breakfast, patient takes a dose before breakfast, boom, covers that breakfast meal. And then it washes out, and by the time it is lunch, patient again takes it 15 to 30 minutes before, boom, covers that mealtime glucose spike. And that's, that type of insulin dosing is called bolus insulin dosing. And you'll hear it referred to in a basal bolus insulin regimen, and I'll go over the basal in just a moment, but when you hear basal bolus, the patient's on basal bolus insulin, it means that they're on a rapid acting, and then they're on something else for the basal, which we'll get to in just a second. Short acting, so this is it's just a semantics game, really. Rapid acting, short acting, but regular insulin is the short acting insulin, so it's the only one in this particular category. And prior to the advent of the rapid acting insulins, we kind of used regular insulin like the rapid acting insulins. You would take it usually before meals. It had an onset of about 30 minutes, which is nice. But check this out. The peak effect can be up to 2 hours. And it hangs around, the duration of it is 8 hours. So you kind of lose that Ferrari-esque control that the rapid-acting insulins offer for controlling blood glucose associated with the meal. Don't get me wrong, it'll still work, but it's just going to take a little longer for it to reach its full effect. And it's going to be hanging around for, at least a couple more hours compared to the rapid acting. Why is that important? Well, the more it hangs around, when you don't need it, the higher the chance that you have the most dreaded adverse effect of insulins, which is hypoglycemia, which of course can be deadly. I will say that Regular insulin is the only one that can be given intravenously. This is important when you're taking care of a patient with like diabetic ketoacidosis. Like, you don't really, usually time is of the essence. So the faster an insulin can work, the better. So a lot of times in the management of diabetic ketoacidosis, you'll give IV regular insulin. And of course, all those PK parameters that I just talked about, they just all go out the window because obviously you're directly injecting it. So the onset is, just a couple minutes or so compared to subcutaneously. You can see the profile of short-acting insulin here. And then think of those Lispro spikes that we just talked about. So this is actually even better. So you can see that compared to the Lispro spikes, that the regular insulin takes longer to hit its peak effect. And then check this out. It's not even washing completely out by the time we get to lunchtime. So when we get to lunchtime, you might have some dose stacking going on because you have some insulin still in the body. So why in the world would anyone outside of having DKA or another indication for rapid insulin therapy where it needs to be given IV, why would we ever use regular insulin? Well, sometimes it's really our only option. So regular insulin is historically cheaper than the rapid-acting insulins. Depending on the state you're in, too, you can actually buy regular insulin, not over the counter, but behind the counter. Like the pharmacist can sell it to you. So there's not like eliminates a barrier sometimes for patients that, aren't able to get a refill in or whatever. The other instance where you might want to consider regular insulin is it's compatible in the same vial and in the same syringe with intermediate acting insulin. But basically, it affords this dosing strategy, which I'll describe in just a moment, this NPH regular combo product, which you can see is only 2 injections a day. It's just like a simpler dosing regimen that doesn't give you as good of blood glucose control, but it's simpler for patients. So sometimes that works better for them, and that's totally okay. But tell me more about that intermediate acting insulin that regular insulin can be in the same vial with, and that's it's going to be called NPH, is what almost everybody on God's green earth calls it, NPH insulin. NPH stands for neutral protamine hagedorn. I'm sure there's a really great story behind that I've not looked into. Note to self for next year. Or sometimes it's called insulin isophane. All the same thing. In intermediate acting insulin is really just that controller insulin. And it really owned that indication for so many years, because for so many years it used to be the longest acting insulin available, and was really used to kind of keep patients' blood sugar at bay in between meals and at nighttime. And you can hopefully see why it's absolutely terrible for trying to target like a postprandial glucose spike. You can see with this onset of up to 2 hours. It takes 4 to 12 hours to hit its peak. And then it's got a very long duration. So it would be very problematic, and I can't think of anybody in their right mind that would try to use NPH insulin to control postprandial blood glucose spike. But it does do the job for, being a controller insulin or a basal insulin. And when it's mixed with this regular insulin, like in this figure, you can see by the time the regular insulin wears off, hey, check this out. We got some NPH still hanging around, which is covering us in between meals. I presume the S here means supper, so this is a very scientific figure. But you can see that after the regular insulin washes out and the patient is in stage 4 REM sleep in bed, the NPH is still hanging around to keep that bedtime blood glucose in check. And then finally, who unseated the king? What contributed to much less use of NPH when we used to have really only NPH as our longest acting choice? Well, we have the bona fide long-acting insulins. So glargine, Detamir had been around for a pretty good while, and this was something that I didn't have on my bingo card, but it was actually pulled from the market, not because it did anything bad or anything like that. I guess the manufacturers of Detamir just got tired of losing to glargine. Most people are on glargine. You might know it as Lantus. That's what, outside of an academic environment, I'd say most people refer to it as. And then there's Degludec, which I can't tell you if I've ever seen anyone on that. But they all work the same. They have a very, very slow onset, which is okay. That's totally fine because we are not banking on these drugs to control any sort of blood glucose spike associated with eating. We just want them to work in between meals and at nighttime. And sure enough, they're dynamite for that. They are long-acting, so they're usually just taken once a day, and that kind of covers the patient's basal insulin requirement. A lot of times, obviously if you have type 1 diabetes, you go straight to insulin. There's really, there's no other choice really. But if you have type 2 diabetes, usually, so the story goes, you try to control the disease with oral therapy, and that sometimes is effective, is sometimes not effective. And if it's not effective, like that next step is usually a patient getting put on one of these basal insulins. So a lot of times they'll be on oral anti-diabetic meds, and then they might just be on a long-acting insulin. As the disease starts to progress, though, the oral agents start to fall off, and the patients start to gradually become more of an insulin-focused regimen instead of the orals. Here are those curves once again. I just want to show you all something that is you might hear, and I want to provide the necessary context. So for these long-acting insulins, Detamir, glargine, and Degludec, a lot of times people will refer to them as peakless insulins. So the reason why some people might mention that they are peakless is that without a pronounced peak, I'll say, they have a much lower incidence of hypoglycemia compared to the short or the rapid acting insulins, or even the intermediate. This figure does a good job clearly showing glargine and Degludec, are just pretty much plateaus. Detamir, you do get a little bit of a peak, I'll say, but compared to the others, it's much less pronounced. All right. Okay, so really if your ultimate goal is to slow the progression of diabetic nephropathy, retinopathy, decreased cardiovascular event rates, etc. No question about it, you should be on that basal bolus regimen. That basal bolus regimen is simply in the middle panel there, the bottom. It's being on a rapid-acting insulin and a long-acting insulin. And you can see you take the rapid-acting insulin around meal times, and then you have the basal insulin, in the background, kind of taking care of things. So you might be thinking, why is everybody not just on basal bolus? Like, if it's the best for controlling some of these really terrible long-term consequences of the disease. Well, everything comes at a price, and the price you pay is more hypoglycemic episodes. So that's what this figure is showing over here on the far left. In panel A, you can see the intensive therapy is associated with more hypoglycemic episodes compared to quote-unquote standard therapy. But then conversely, on the next panel over, you can see that the intensive therapy has a much lower rate of these complications associated with diabetes. And most people feel like the trade-off is in favor of the more intensive therapy. Now, of course, everybody's different. Every patient's different. So, your 95-year-old grandma that, is still sharp as a tack, living alone, but maybe she doesn't, see too well, and do you want her like drawing up insulin doses and, potentially having a hypoglycemic episode, versus like a 18-year-old newly diagnosed diabetic that has to live with the disease for presumably several decades. But that hypoglycemia, those telltale signs of it, of course, you get hangry, weakness, shakiness is very pronounced. Patients will become diaphoretic, have tachycardia. And if you'll remember many moons ago when we were talking about hypoglycemic unawareness, particularly when it came to beta blocker therapy, beta blockers can mask some of these symptoms, so they can help mitigate the shakiness, they can help decrease the tachycardia, and that's why you'll see warnings about giving beta blockers to patients with diabetes because it increases their risk of hypoglycemic unawareness. But I'm sure you remember at that time I gave you all a super long, convoluted explanation as to why that's usually okay. You just use beta-1 selective agents, et cetera, et cetera. Some of the more mechanical problems associated with insulin therapy is when you start injecting yourself, and usually most people will use the stomach or abdomen, but there's other places, but every single freaking day, sometimes 4 times a day, you start to develop these like little knots almost in the injection sites. So you get this lipodystrophy, and the whole outward appearance, I guess, of where they usually inject themselves can start to look a little bit odd and have like little, almost like knotted areas. And there's things you can do to lessen that. Maybe you alternate between the right and the left hand side of the abdomen. Maybe you do, under the arm and the subcutaneous tissue there. Maybe you do the inner thigh sometimes, but very, very common adverse effect that manifests. And of course, we lose our vanity a little bit because, insulin, it helps package those sugars in the cell, and usually there'll be some weight gain associated with it. All right. Very minor supporting character to insulin, but technically is a parenteral anti-diabetic agent, is pramlintide, which is an amylin analog. What in the world is amylin? Amylin gets co-secreted from insulin with the beta cells. And what's interesting, it's different, but what's interesting is that you'll get a lot of the physiologic effects that you see with some of the more popular anti-diabetic agents, like the GLP-1 agonists. You get decreased glucagon release, decreased gastric emptying, increased satiety. Oh, hold on now, what's going on? But it's weight neutral. Why? That's a good question. I honestly, I don't know why it's weight neutral. It has all the markings for it to be, to cause weight loss, but it's considered a weight neutral anti-diabetic agent. It's basically used as a booster, and this is why you probably do not see many people on this drug, because it's not doing the work itself. Like, it can't do it. It needs to be there. It needs to be given with insulin. And so if your patient is already on insulin, and let's say they're on 10 units of insulin, just for hypothetical, and they need a little bit better blood glucose control, do you tell them to just draw a little bit more up and do 15 units? Or do you use 10 units and then introduce a new drug that has its own set of adverse effects and the patient has to pay for a separate drug, et cetera, et cetera? So it's usually just easier to give more insulin. You're already on insulin. Once you're on insulin, you're basically not coming off. Very rarely do you come off of it. So usually we just increase the insulin dose and we don't really mess around with adding this drug. It can cause things like hypoglycemia and nausea, but if for some strange reason someone were to take this by itself without insulin, it won't cause hypoglycemia by itself. Hypoglycemia is just basically like an attenuation of the effects of the insulin. It's not necessarily that this drug itself is causing it. And nausea, you'll see, is like a super common adverse effect with a lot of these drugs that work through GLP type pathways. Even though this is not necessarily a GLP agonist, it kind of has a lot of the same end physiologic effects. Okay, we danced around it. Let's talk about the darling of the past couple years, the glucagon-like peptide agonists, the GLP agonists. I think we talked about erectile dysfunction, didn't we? I think so. We talking about okay, gotcha. So yeah, and erectile dysfunction, I think we're talking about I was going to open up a pharmacy with my brother-in-law, ex-brother-in-law, and we were going to make some money off of Trimix, which was that erectile dysfunction combo product we were going to compound. But this was going to be the major money maker. This was going to be if it had gone through, I probably would, roll up to the MEB in a lime green Lambo. Tons of money to be made in this space. These drugs have just really been totally blockbuster drugs. They are peptides. So, if you hear RFK Jr. is really big into peptides, he wants to loosen the restrictions on peptides and whatnot. These are already FDA-approved peptides, but he's talking about others that are kind of more in the experimental realm. But these drugs, they kind of have a very interesting origin story. Real quick, they're pretty easy to identify if it ends in basically tide, whether it's eutide or atide. But really the first one that came out on the market was in 16. So about 20 years ago, exenatide. No one cares about exenatide. Nobody talks about exenatide anymore. But exenatide was kind of the pioneer. Interestingly, its inspiration was the saliva or venom from a Gila monster is how they eventually ended up with this drug. But that's beside the point. So exenatide came out about 20 years ago. Why did we not have this explosion of these drugs at the time? Well, we did. We had a little bit of a mini explosion, but it wasn't sustained. What happened when exenatide came on the market is that no one could really find it. No one could really buy it. And it was crazy. Like the drug manufacturers, where we thought we produced enough, et cetera. It turns out one part of the country was buying up the whole supply of exenatide. It was just so funny to me, but South Beach, Miami. Yes, South Beach, Miami. They were just going out the door like crazy at the CVS's and Walgreens, I guess. And so there was a period of time where it wasn't really available, and there was a lot of excitement about it. But what ultimately killed that excitement, though, is exenatide was you had to give yourself an injection twice a day. And it was just not really super easy to stay on it. And so enthusiasm for it died down. But the real game changer was when these longer acting GLP agonists came out. So semaglutide or Ozempic, as some people refer to it, that really was kind of the first one to really master the once weekly dosing regimen. And then, it obviously caught on like wildfire. So yeah, it's all in the news, everything like that. Novo Nordisk, the manufacturer of semaglutide. I don't know if you all for a little while these drugs were not really available, particularly in COVID, during the COVID era. And so a lot of compounding pharmacies got in on the action, and they started making it themselves with raw ingredients. And the FDA allowed it. And it's almost like the genie was out of the bottle at that point, though, because the FDA allowed them to compound it because it was on shortage. None of these drugs are on shortage anymore, but you see advertisements for it all the time, like all these companies, Hims or Hers, and you can do like a teledoc appointment, and someone will write you a prescription for it. And the reason why you see so much use of it is those compounding pharmacies are still making it, but they tweak it just a little to where it's actually not the drug. So they might just attach a B12 molecule to it, or they'll attach a glycine molecule to it. And it's not semaglutide anymore. It's semaglutide and glycine. So there's all these games being played right now, and they're still widely available. And that really just kind of, Novo Nordisk, which I believe is based out of Denmark, once all these compounding pharmacies were making it, I think that it's something absolutely incredible. Like the GDP of the country dropped 90%. Like Novo Nordisk was making so much money on this drug prior to it being on shortage and all the compounding pharmacies getting in on the action that once it was available and they weren't making that money anymore, they had a big hit in their GDP. And then also another thing that kind of decreased the use of Ozempic or semaglutide is tirzepatide. So I don't know about you. I don't know if you have anybody in your life that's on these drugs particularly for weight loss. For diabetes, it really doesn't matter. But some people are very particular. Like, no. I don't want semaglutide. I want tirzepatide. Or they'll say, I need Mounjaro. Yeah, that is the good stuff. Because it's also a GIP agonist. So it basically is a little bit more potent. So it's not only a GLP-1 agonist, but it's a GIP agonist. But a lot of you get an exaggeration of those physiologic effects, primarily the delayed gastric emptying and the increased satiety. And your friend is not crazy, too, because actually there's literature to back it up. More people lose weight on tirzepatide compared to all the others in the class. So don't laugh at them. So when it comes to mechanism of these drugs, similar to the amylin analog, they decrease glucagon release, they increase insulin resistance, decrease gastric emptying, and increase satiety. So really interesting that, you get really marked weight loss with these drugs, but not really so much with the one I just discussed previously. But it's all in the news. Sharon Osbourne, pre-GLP-1 agonist therapy, over there on the left. And then, just looking a little skeletal after being on it for some time. It's totally, it's everywhere. I can't wrap my head around it anymore at this point. Like so many people being on it and like just how much their bodies can change. They are not benign though. They are not benign. Adverse effects, obviously weight loss. Pancreatitis is one that is pretty rare, but certainly can occur. I would say the number one reason why people stop taking these drugs is due to the GI adverse effects, particularly the constipation. They also can cause diarrhea too. Most people will say that they get constipated on it, but actually there's some pretty good evidence that they can cause diarrhea. So it can kind of make you feel like your guts are just like churning in on themselves. And then most of them have this black box warning for thyroid cancer or multiple endocrine neoplasia, or if you have a history of that in your family, you shouldn't be on these drugs. And then there's some other ones too. There's some fringe ones out there, which I'm not saying are not true, but you have things like depression. Some people are saying it causes psychiatric symptoms. There's concerns that it may cause increases in osteopenia and osteoporosis because I guess presumably instead of like eating more of a well-balanced diet, you have like, I don't know, one grilled cheese sandwich a day or whatever that looks like. And then you hear about sometimes patients, unfortunately, they'll get this gastroparesis, or they're a frozen stomach after they're not even on the drug anymore, but their stomach just doesn't move food through to the lower intestine, so they get this gastroparesis, which is like super painful and not benign, but all in all, pretty well tolerated. And then, in case you're wondering, sorry, I kind of went on a little bit, went heavy on the weight loss aspect. In case you're wondering, for their use in diabetes, they're not like, they're pretty much on par with alternative options. So they're not going to turn a patient's whose A1C is 13 to like 6. They're not going to do that. They might drop the A1C by 0.5 or 1. Probably more likely it's going to be like a 0.5 drop. So they are effective for diabetes. But if your main goal is just A1C lowering, there's other options out there. A lot of times, particularly with our type 2 diabetic patients, they may benefit from the weight loss effects, so it's kind of like a twofer in that case. But all right, and what a great time to take a break. All right. Go ahead, keep on keeping on. So next up, there's really not too much else to talk about when it comes to parenteral agents. We'll go into the oral agents where there's a little bit more, I guess, variety and spice, I'll say, with mechanisms and choices and whatnot. And the first one is pretty much the MVP for type 2 diabetes management, technically part of the biguanides, and that's metformin. Metformin, usually if you look at ADA guidelines and you're trying to figure out, what you need to do for your newly diagnosed diabetic patient, it's probably going to point to metformin. Usually the stepwise approach is therapeutic lifestyle interventions, like through diet and exercise, and particularly if the patient has prediabetes. And then if that doesn't work, we'll recommend adding on metformin as a first step. Metformin is really interesting in that it has multiple mechanisms of action. It decreases gluconeogenesis, decreases absorption of sugars, and has increases sensitivity to glucose in those peripheral tissues, which is super problematic in type 2 diabetes. One of the important things to note when it's monotherapy, so when it's used by itself, super low chance of hypoglycemia. If someone is just on metformin, they are usually not becoming hypoglycemic unless there's a little bit more to the story, like they're on a 72-hour fast and they're still taking their metformin or something like that. But just usually not something you have to really worry about. The adverse effects of metformin, GI adverse effects, I know that's every drug, but it's especially pronounced with metformin. And because of these GI disturbances that metformin causes, a lot of times you'll get some weight loss too from it, whether intended or not. Not on the same level as the GLP agonists, but you will get, it's common to see a modest, it's not super striking, but a modest weight loss on it. Long-term, patients can develop a B12 deficiency due to impaired absorption of B12. That's just a very weird, random thing about metformin that you should just really just kind of keep in mind. One last thing I do want to point out about the GI adverse effects is with metformin, there's immediate release metformin tablets, and then there's extended release metformin tablets. And what's funny is this is the only drug I can think of where this is the case. So usually if a drug is available as an extended release product, the thought is that you want the effect to persist over usually 24 hours or so. And certainly the extended release metformin does do that. But the whole reason why extended release metformin even came about is because it slowly releases the metformin. It has a much lower rate of those GI adverse effects. So the primary reason why we have extended release metformin is not necessarily compliance, improving compliance, once a day administration instead of twice a day administration. It's actually that lower incidence of those GI adverse effects. So usually if someone takes metformin immediate release and they can't tolerate it due to the GI adverse effects, switching them over to an extended release, a lot of times will fix the problem. But the most The scariest adverse effect of metformin is lactic acidosis. You will see a full-on stop, full-on contraindication, not a warning, not a, hey, think about this, but do what you want to do. It's, do not give to patients with severe renal dysfunction. And that's legit. That's something that you definitely do not want to mess with. And the concern is with developing this lactic acidosis, which can be fatal. It doesn't really happen all too often because everybody is so hypervigilant, I feel like, in preventing this adverse effect. But in some overdose scenarios, you can see patients develop lactic acidosis. But it's pretty rare to see someone that's like just taking it therapeutically. And there's really good information out there on like when you should discontinue therapy. It's not like a real nebulous answer. I believe it's like a creatinine clearance less than 30 is when it's contraindicated. So there's not too much guesswork on when it's too dangerous. Sulfonylureas, usually you can see there's 3 in the class: glyburide, glipizide, and glimepiride. These were one of the first oral anti-diabetic agents available on the market. And certainly they are used pretty commonly still to this day, but their use has kind of like dropped down by the wayside because they're good, I guess, at lowering A1C, but they also are good at causing hypoglycemia too. They had this really interesting mechanism, and that by blocking the potassium channel on the beta cell, it caused depolarization and calcium influx, which then will cause insulin release. So you're basically just like forcing the pancreas to secrete insulin by blocking these potassium channels. As I mentioned, they are associated with hypoglycemia. Really that's you should be doing everything in your power to mitigate that risk. So like that's, for example, one of the examples why metformin is so popular is because it has a very low risk of hypoglycemia. Some of them are renally eliminated. More specifically, glyburide has a pharmacologically active metabolite that's renally eliminated. So you have an increased risk in patients with renal disease. So glipizide and glimepiride are the easier options there. Outside of weight gain, outside of hypoglycemia, these drugs are associated with weight gain, which hopefully is not too surprising because they're basically sort of kind of arriving at a similar endpoint to giving exogenous insulin. Rather than it coming from a syringe, it's just you're basically like whipping the pancreas to secrete more insulin. The glitinides, but really the appropriate way to refer to them is the meglitinides, are very similar to the sulfonylureas, very similar mechanism of action, and really kind of the devil is in the details with them when it comes to their pharmacodynamic profile. And that's that they have a rapid onset and a short duration of action compared to the sulfonylureas. So the sulfonylureas, we're talking about once, twice a day administration. The glitinides, you literally take a tablet before every meal. So they're kind of used as a like an oral rapid acting insulin, like a Lispro or an Aspart, and they're not super popular, to tell you the truth. Usually, patients are on a whole host of other oral meds before they find themselves on a glitinide, but they do have the same adverse effects that you're going to see with your sulfonylureas. Absolute 100% no-no is to use them with a sulfonylurea, because hopefully that makes sense. It's basically the same mechanism of action, so you either commit to one or the other. If someone's on a sulfonylurea and their blood glucose is not under control, you can pivot and try a glitinide, or if the dose is not optimized, perhaps you just increase the dose of the sulfonylurea, but you don't add a glitinide on top of a sulfonylurea. That's probably why they're not used all that often, because usually the answer in that scenario is just increase the dose of the sulfonylurea. The dipeptidyl peptidase 4 inhibitors, or DPP4s, similar. Check out this mechanism of action. This enzyme, DPP4, it actually metabolizes GLP-1 and GIP, which is the one that tirzepatide is an agonist, has agonist activity like, but it basically is kind of like augmenting the body's own GLP-1 and GIP. And not surprisingly, you see a lot of very similar, end effects. Have more insulin release, glucagon release goes down. Again, the gastric emptying and the satiety, gastric emptying goes down and satiety goes up. But again, this is one of those ones where I don't really have a good reason why the weight loss is not realized in the literature with these meds. But they are weight neutral, so they're not really, your patient really shouldn't expect to lose really a significant amount of weight on them. They have these absolutely bizarre adverse effects of increased respiratory and urinary infection. I've never read a good explanation as to why that is. It's just a quirk with the meds. Pancreatitis, though, similar to, if you'll remember, pancreatitis was an adverse effect associated with the GLP agonists, and hopefully that's not too much of a surprise if you're just like augmenting the amount of endogenous GLP the patient's producing. Of course, you can see pancreatitis. But these are some, they don't cause hypoglycemia too. So it's really popular to put them in a combo pill. So Janumet is metformin and sitagliptin. So a lot of times there'll be these combo pills of metformin plus a DPP4. Lots of people are on a regimen like that because low risk of hypoglycemia, and their effects complement one another. All right, so now let's talk about some oral anti-diabetic agent class, which is very rarely used for diabetes. I mean, to some degree it is, but really just has taken off like a rocket in terms of management of heart failure, and also in patients with, they've been shown to help slow the progression of chronic kidney disease. But they started out as anti-diabetic agents, and they have an FDA indication for it, and some people take it for that. And this is our sodium glucose cotransporter 2 inhibitors, or SGLT2s. They have this really funny ending of Flozin. And how they work is they block reabsorption of glucose in the proximal convoluted tubule, basically trapping it in the lumen of the nephron. And you just excrete out more glucose via the urine. Obviously, patients need to have functioning kidneys for this to be a successful venture. But it's really part of the reason why they are not used all that often in the management of diabetes is infection. You can think of like you make a nice, delicious, syrupy urine for microbes. They like that. They love it. Very common adverse effect associated with this are things like UTIs and candidiasis, hypotension. That's kind of a lame adverse effect. I just threw it on there because I think I saw it in a STEP material book. But theoretically, you could pee out so much from the osmotic effects that you would become dehydrated and become hypotensive. So, as you can tell, I'm a little cynical about that, but it's something you'll see. And then this absolute bizarre adverse effect of euglycemic diabetic ketoacidosis. So you will see patients with a quote-unquote normal blood sugar, but then they have decreased serum bicarbonate. They have evidence of ketone bodies in their blood, and similar concerns that patients can become profoundly acidotic, and it can actually be a critical thing that needs to be taken care of ASAP. So that's a very very unique adverse effect to this class of medications. So while we thought that this class of meds was on its deathbed, it literally was. They were literally on their way out until they found through a subgroup analysis in heart failure patients the improved mortality, and then that changed everything. Now they're standard of care in the management of heart failure as a mortality reducing agent. So they're not going anywhere. If your patient has heart failure and diabetes, hey, this is a twofer. Maybe you can kill two birds with one stone. The thiazolidine diones, this is a slide I updated this morning. Sorry, I literally just realized that rosiglitazone is not available anymore. Not exactly sure when that got pulled off the market, but here in the good old US of A, we just have pioglitazone. For the longest time, we had rosiglitazone and pioglitazone. And these thiazolidine diones, in the 2000s, so prior to 2010, but in the 2000s, super popular class of medications to be used for diabetes. They're agonists at the PPAR gamma receptor, and basically all that they do is they just increase insulin sensitivity in adipose peripherally, so you get your body is more sensitive to the effects of insulin. By themselves, they have a very low risk of hypoglycemia. This is all sounding really good. This is like my holiday wish list for what we want in a diabetic agent. But what changed, though, is what initially manifested and was understood to be an adverse effect of the drugs was weight gain. We were cool with that. Had a little bit, and that was thought to be mostly driven by increase in fluid retention, essentially, but also some increase in subcutaneous fat. But the increase in fluid retention was especially problematic because what eventually ended up happening is we were like, whoops-a-daisy, this is actually not a good choice for patients that have any sort of symptomatic heart failure. So, someone that gets winded, walking up one flight of stairs versus someone that's winded just sitting on their couch, like we realize it is detrimental across the whole spectrum of symptomatic heart failure. And they picked up this black box warning. Just as a refresher, black box warning, highest warning the FDA can issue for any medication that literally is in a black box at the very top of the package insert. So that really, scared, I'll say, a lot of the use and drove down the use of this med. The rosiglitazone even had its own unique adverse black box warning. It also had the same one about heart failure, of course, just like the pioglitazone. But the rosiglitazone also had a black box warning for increased risk of myocardial infarction. So that's probably why it got pulled off the market. So I'm just surprised it lasted as long as it did. So just really pioglitazone is the only one available. Really strange adverse effect associated with this class of meds is osteopenia. Bless you. So now we're kind of moving on to some even more, I guess, lesser used drugs, the alpha-glucosidase inhibitors. So similar when I was talking about the drug orlistat at the beginning of the session, and that drug prevented the breakdown and absorption of fats. Alpha-glucosidase inhibitors, they inhibit, yes, you guessed it, alpha-glucosidase. What's the point? Well, that enzyme breaks apart carbohydrates into just a simple sugar, like glucose, so that it can be absorbed. And less glucose being absorbed equals better blood glucose control, hopefully. You can imagine if you have all these carbohydrates just chilling out in the lumen of your intestines, increasing the osmolarity of the slurry in your intestines, you're going to start pulling fluid into the lumen of the intestine and get things like GI upset and bloating. So their GI adverse effects are the main ones to be aware of. All in all, they are pretty hard to get in like serious trouble with. Really no hypoglycemia or anything like that. But really they're not doing anything per se with, they're basically just manipulating the absorption of glucose from food. They're not really doing anything in the body. So a lot of times by changing diet, you can just not have to worry about using a drug class like this, and part of the reason why they're infrequently used. Oh boy. All right. Let's take me home. Let's do a summary real quick. So when it comes to hypoglycemia, I know I just barraged you like a million different class of medications. So really, it's going to be those drugs that are actively causing insulin secretion. That's the telltale sign that you have to worry about hypoglycemia. Any sort of those drugs that we discussed that increase insulin sensitivity or decrease glucagon release, stuff like that, those really don't really cause hypoglycemia by themselves. So the glutamides and the sulfonylureas really known for causing hypoglycemia. And part of the reason why I said they're not really used too often, or they're usually not our go-to agent. GI disturbances, biguanides, so that's metformin. Remember I told a whole story about extended release metformin only really came to be to help mitigate the GI disturbances, not necessarily we cared about the effects lasting over the course of a day. Those alpha-glucosidase inhibitors we just discussed, remember you have those carbohydrates that are not getting broken down and absorbed and can cause GI disturbances. Sulfonylureas, the glutamides, and the TZDs. So sulfonylureas and the glutamides increasing that insulin release. So similar to just taking insulin out of a vial, you're going to see things like weight gain. The thiazolidinediones, they just increase that peripheral tissue sensitivity to insulin, but remember that probably more so what is driving the weight gain is that increased fluid retention that's realized with them. That's how they picked up that black box warning to not be used in symptomatic heart failure. Biguanides, metformin, it's kind of related to the GI effects. The DPP-4 inhibitors, pancreatitis. Remember, these drugs are sort of kind of causing an effect like the GLP agonists. So those GLP agonists can cause pancreatitis, and sure enough, the DPP-4 inhibitors can. SGLT2 inhibitors, remember they cause glucose to get sequestered in the urine, creating a nice environment for microbes to set up shop. And this is just kind of more of just like a broad overview of what we discussed, and the differing duration of effect of these drugs, and hopefully it makes a little sense. Like the repaglinide, remember those are the glutinides that you take with the with food, so it makes sense that you only have a duration of 2 hours. Contrast that with like long-acting sulfonylurea like glimepiride. Those are just like once-a-day meds. So that's just more FYI for you. Of course, I would never in a million years ask you a test question: how many times is this drug taken versus that drug? And this is just an oversimplified graphic of basically the ADA guidelines on management of patients with diabetes. You're going to see up there, top left-hand corner, they are really pressing for that metformin. So metformin usually is going to be part of that management in a patient with type 2 diabetes. And then depending on what else is going on with the patient, right? The compelling indications. When we were talking about hypertension, we were trying to kill as many birds with one stone as possible. So we're trying to treat the we're trying to treat the diabetes, but if we can also give them a drug that gives them a mortality benefit for their heart failure, that's a win. All right, corticosteroids. This is probably going to break y'all's heart, but we might finish early today. See how long I can drag out these last 4 slides or so, okay? Corticosteroids. It's going to be difficult because we've talked about corticosteroids a lot before. So, so we've always talked about them in a specific context of, like for asthma exacerbation. But we haven't really talked about them from really too much of an endocrine standpoint. So that's more or less what I want to cover in these last couple slides. I know you're familiar with the mechanism, but I'm just going to kind of highlight some of the differing activity between the corticosteroids to just basically close the loop. Obviously, they're used for so many different disease states, and can be delivered via so many different routes that you probably will have patients that are on corticosteroids that you're taking care of, and then what you have to ask yourself then though is my patient on corticosteroid for the glucocorticoid effects, or do I want them to be on a corticosteroid for their mineralocorticoid effects? And I'll discuss that in just a moment. But first, I'll talk about the glucocorticoid effects. And that is, when we've talked about these drugs previously, that's really kind of what we've dialed into. This is just as an oversimplification, the anti-inflammatory immunosuppressive effects of glucocorticoids. So a patient with lupus, or a patient with asthma, or a patient that got into some poison ivy. Very different scenarios. The glucocorticoid effects of steroids could be used for all of those for their anti-inflammatory activity. our body naturally tries to, create those anti-inflammatory effects with cortisol. But sometimes it needs a little help. And those anti-inflammatory and immunosuppressive effects are super pronounced with steroid therapy. And that's part of the reason why it was really sad when the party was over and we realized steroids had all these horrible adverse effects. Because back in the good old days, there was nothing finer than a corticosteroid for anti-inflammatory and immunosuppressive effects. And part of that reason was that they actually inhibit phospholipase A2. Remember, phospholipase A2 is basically that first step to the eventual generation of prostaglandins and leukotrienes, which are inflammatory. So if you can prevent that phospholipase A2 from ever getting dislodged from the cell membrane and getting turned into arachidonic acid, you're going to have a very pronounced and effective anti-inflammatory response. Also, just across the board, other independent mechanisms such as stabilizing mast cell membranes, so you get decreased histamine release. Really just fantastic class of medications if you're just looking at one side of the equation, the efficacy side. One thing to note, though, is with glucocorticoids, is, check it out, just as a reminder, they really don't do much of anything quickly. Why is that? Well, because they have to go make their way into the cell, and then they have to bind to this cytoplasmic receptor, and then this complex then gets shepherded into the nucleus of the cell. And then eventually you see changes in the amounts of proteins that are coming from the cell. So if your patient has they got stung by a bee and they're swelling up everywhere, yes, you will give them a corticosteroid. But it's not really going to do much for them in that moment. What's going to help them is that epinephrine pen. That's what's going to get a handle on top of it right then and there. The thought is, though, with the glucocorticoid effects, which take hours to manifest, is preventing any sort of biphasic reaction where once the epinephrine wears off, the patient then swells up like a balloon again. So they are not quick working, and that's by virtue of them, having to, go into the cell, bind this cytoplasmic receptor, make their way into the nucleus. So the other effect of glucocorticoids, is the mineralocorticoid activity. We almost never talk about this, and trust me, sometimes, in some patient cases, yes, that is important, but I'd say 95% of our use of corticosteroids is for those glucocorticoid effects. The mineralocorticoid effects really cause an increase through their effect on the nephron, an increase in the reabsorption of sodium primarily. And remember, where does water want to follow? Water wants to follow sodium. So if you have an increase in the amount of sodium being reabsorbed, you have an increase in water being reabsorbed as well. And you also get some other, changes, I'll say, in the nephron, a decreased reabsorption of potassium and hydrogen ions. If you'll remember when we talked about spironolactone and eplerenone, those and heart failure and diuretics, those were mineralocorticoid receptor antagonists, or MRAs, and they block mineralocorticoid receptor. So they would be antagonists there. But here we're talking about what happens, what do the agonists do in this site. End result is being an increase of sodium reabsorption and usually like an increase in water retention, if you want to think about it in, like end result terms. And that's primarily how they are used. So typically what the situation looks like is, where you might see a corticosteroid with primarily mineralocorticoid activity used is a patient has Addison's disease, and I don't know, they're started on hydrocortisone, for example, and they start to become dehydrated and they start to become hyponatremic, and we're like, oh, we need to do some fine tinkering with their steroid regimen. So really the one that's most commonly used, and I think actually is the only one in the class, is fludrocortisone. You can see don't get me wrong, it has some anti-inflammatory effects, but no one's using fludrocortisone for the anti-inflammatory effects. It's primarily for its mineralocorticoid effects. So, and this nuance you'll notice in certain, lively debates happening. For example, if you look at the literature on the use of corticosteroid therapy in patients in septic shock, so surviving sepsis guidelines, they recommend giving steroid therapy in patients that are hypotensive despite being on vasopressor therapy. They recommend giving corticosteroid therapy, usually hydrocortisone. Well, if you look at the primary literature that recommendation is based off of, in the study actually, they gave fludrocortisone too. So there's this debate in the literature like, well, we can't just give hydrocortisone, we have to give fludrocortisone for its mineralocorticoid effects, because we can't say, whether the benefit is due to just the glucocorticoid effects. So that's, to make a long story just a little bit longer, these mineralocorticoids are pretty much used for their sodium retaining and water retaining properties. Oh my gosh, this slide again. Yes, steroids, they have tons of bad adverse effects. That's, that's pretty much the moral of the story there. Pretty intuitive. The higher the dose of the steroid you're on, the more likely you are to have an adverse effect. So, we try to get patients off steroid therapy. Sometimes that's not a realistic goal. And then the goal changes to we need to get them on the lowest dose possible. Okay, let's run through some questions, friends and family. Which of the following statements is correct regarding lisproinsulin? Is it used primarily to control postprandial hyperglycemia? Does it have a peak? Does it associate with albumin and that interplay feeds into its duration? Or should you not use it with a long-acting insulin like glargine? What's on y'all's mind with this one? Yeah, absolutely. So it's primarily used to control postprandial hyperglycemia. Lispro, Aspart, glulisine, those are the three rapid-acting insulins. It certainly does have a peak. It has, a peak that it can be very proud of. That makes absolutely no sense about associating with albumin. And that is its bread and butter to be used in a regimen with a long-acting insulin like glargine. That's the textbook definition of a basal bolus regimen, which we love so much. Patient with diabetes is currently being treated with insulin Lispro. The physician determines that the patient needs basal insulin therapy for control of elevated nighttime blood glucose values. Which of the following is going to do that? Regular insulin, glulisine insulin, Aspart, or glargine? I heard the glargine, yes. Good job. Regular is a short-acting insulin. Pretty much functions like a rapid-acting insulin. Not quite as nice. Not the cleanest PK profile. So that would not be a good choice. And then glulisine and aspart are the same as Lispro, rapid-acting. How should a patient prescribed Lispro insulin be advised to take the med? Take it in the morning, take it at night, take it whenever they please, or 15 to 30 minutes before a meal. What do we like, A? No? Okay. Yeah. So as you can tell, I am really beating this dead horse on knowing the nuance between the different types of insulin. So let's talk about something else. Oral diet, which of these drugs is paired with their mechanism of action? Is it DPP-4s, prevent the breakdown of complex carbs? Is it SGLT2s, increase urinary excretion of glucose? Sulfonylureas, increasing insulin sensitivity? Or the thiazolidine diones, decreasing hepatic gluconeogenesis? Yes, B. Excellent. Thank you. Increased urinary excretion of glucose. Ooh, here we go. This is one forged in the pits of hell. Which of the following drugs is most likely to cause hypoglycemia? We kind of did a whole song and dance about what to look for for an oral drug to cause hypoglycemia. Yeah, right on. Glyburide, right? All these other, so the exenatide, that's the GLP drug. So that's going to do things like, obviously, decrease glucagon secretion. It's going to do things like slowing down gastric emptying, increasing satiety, but not really mess with blood glucose by itself. Rosiglitazone, that's an insulin sensitizer, if you will, for the peripheral tissues. And saxagliptin is that DPP-4 inhibitor that is going to sort of kind of get you to some similar results as a GLP-1 agonist. Which of the following combos of drugs have overlapping mechanisms of action? Is it glipizide and repaglinide? Is it metformin and empagliflozin? Is it metformin and semaglutide? Or is it sitagliptin and pioglitazone? Ooh, what were the drugs that have very similar mechanisms? And I said, you would just increase the dose of one rather than usually adding another drug on top of it. Right on. A, right? Glipizide being a sulfonylurea, repaglinide being a glipizide. Remember, they both block that potassium channel, causing insulin release. And it's one or the other. You can't have both. Oh man, there's you know I'm a sucker for these questions. What's gonna impair the drug from being absorbed? What's gonna impair that oral levothyroxine from being absorbed? Is it pravastatin, calcium carbonate, metoprolol, or vitamin D? Calcium carbonate. Good old Tums. That'll chelate with the levothyroxine and not allow it to be absorbed. Which of the following is a likely adverse effect caused by levothyroxine? Bradycardia, cold intolerance, palpitations, weight gain. What are we thinking? Thinking palpitations? Yes. Look, here I'm a man of my word, and I bet you're going to run into maybe something similar to this. Pregnant patient with hyperthyroidism. What is it? It's got to be the radioactive iodine, right? That's what I'm thinking. This gentleman nailed it right over here, PTU. It's a one-trick pony. Or actually, it's a two-trick pony. It's the thyroid storm, but also pregnant patients that have hyperthyroidism. And which of the following effects is most likely in a patient prescribed a short course of prednisone? Moody, decreased white blood cells, weight loss, or osteoarthritis? I mean, they affect everything, so. What do you guys think? Nailed it. Mood changes, they actually increase the white blood cells, which is really crazy because we use them as immunosuppressive agents, but basically they cause a demargination of the white blood cells and basically make them stupid and not, act appropriately. It causes weight gain, usually from the mineralocorticoid effects, osteoarthritis. Yes, they can cause that, but that's a years-long issue. Oh, man. Which of the following has the highest mineralocorticoid activity? Yeah, good old-fashioned fludrocortisone, often overlooked, but still important. Yeah, okay. Any parting questions or anything like that? Okay, guys, it's always been a pleasure. Let me know if any questions do pop up. And yeah, that's all I got. Thank you.